let's get this program started. I know we're going to get started now, and more people are going to chime in later on. So we just have to come back and keep giving directions over and over again. For those that are online, please know that this is an Exploring Diversity in the Multiple Sclerosis Community program. And this is a program, well, I am Stuart Schlossman. I'm president and founder of MS Views and News. And we are sponsored today by Genentech, EMD Serono, and Biogen. And we want to thank them virtually, and I'll give them a quick clap, all right? Today's program, we're going to do a little bit different than last week. So today's program, we are going to have Dr. Mitzi Williams speak first. Last week, it was Ms. Sheila L.Thorne spoke, and I want to read you their bios before they begin, and then I'll tell you what they're each going to speak about, and then we will get started. And Dr. Williams first. So Dr. Mitzi Williams is a board-certified neurologist and fellowship-trained multiple sclerosis specialist who served as the founder and CEO of Joy Life Wellness Group, Multiple Sclerosis Center in Noonan, Georgia. She is considered a subject matter expert in neurology, multiple sclerosis, and health disparities. Dr. Williams has over 15 years of experience in the field of multiple sclerosis. She received her undergraduate degree in neuroscience and behavioral biology from Emory University in Atlanta, Georgia, and received a doctorate of medicine degree from Morehouse School of Medicine, also in Atlanta. She completed her internal medicine internship, neurology residency, and multiple sclerosis fellowship at Georgia Health Sciences University, formerly known as MCG, in Augusta, Georgia, where she received numerous accolades and served as chief resident of neurology residency program. All right, that's the bio for Dr. Williams. And now I'm going to read the bio for Sheila Thorne. And I'm doing both right now just to help save a little bit of time. So Sheila Thorne, sorry about that, President and CEO, Multicultural Healthcare Marketing Group. Sheila has spent almost 3 decades designing marketing media and health education campaigns for healthcare organizations at the top 50 pharmaceutical companies from molecule to market. She has worked on behalf of the healthcare industry throughout North America, Western Europe, and Latin America with a focus on communities of color. She teaches and has lectured on health equity and cultural competency at several universities and has given over 250 keynote presentations. I'm going to say over 251 because she spoke the other day too. Conducted workshops on cultural competency and moderated health equity forums on the federal, state, and municipal levels. Thank you very much, Dr. Williams.
Thank you so much for having me back. And I'm so excited to be speaking with Sheila tonight. So let's hop right in. Okay, so the title of my presentation is not MS Views and News, but I am speaking for MS Views and News tonight. So what I really want to talk about is diversity in clinical trials. Obviously, we know that this is an issue that needs to be addressed, but I want to spend the majority of my talk trying to focus on some of the solutions as well as some examples of work that's being done to help improve this area in the field of MS. So as we talked about last time, there is recent research that suggests that the risk for MS is actually highest in Black women, right? And this is very different from what we previously thought when we think about the general population with multiple sclerosis. All right, one of the reasons that this is important, right, is that it's not just about who gets MS, right? So we know that the US is a melting pot and there are many different people of many different backgrounds, people of multi-ethnic backgrounds. But I think that, the piece that is a little bit more concerning is that much of our research shows that the outcomes are different in some of these groups. Now, we don't know if this is for biologic reasons or if it's socioeconomic status, things that we discussed last time. But this was a paper that really was a bit shocking to me. And this paper was published in 2018 by Dr. Liliana Amezcua, who's out at USC in California. And she looked at mortality in people whose primary cause of mortality was listed as multiple sclerosis. And what she found was that more Black people died at younger ages from their MS, which suggested that there was more burden of disease related to MS. So under the age of 55, Black males had the highest mortality rates, and 45 and under Black women actually had higher mortality rates. So I think that, it gives us pause to recognize that this is not just about, putting people in different categories, but really trying to affect outcomes and decrease disability as well as possible mortality for those living with multiple sclerosis. So one of the biggest issues is, how do we determine ethnicity? And we touched on this a little bit in the last presentation. Next slide. When we think about ancestry, right, we need to be thinking about this in more of a biologic sense, right? Because when we think about race, race is based on physical characteristics. But when we think about ancestry, it tells us a little bit more about genetics and how different gene pools or different categories of genes that we have may actually affect different outcomes. Like we know some diseases are more common in certain ethnic groups versus others, and that there may be differences that may affect some of those outcomes. And so we have to begin to look at things that are more biologic based, although we do know that outcomes are affected by race, largely because of things like bias and, systemic racism. But we want to begin to look at things on a biologic basis. And research is really the way that we get to do that. So this was a very interesting article that was published in the Journal of American Medical Association that looked at the different disparities and inequities in various ethnic groups in the United States. And so what they found was that low socioeconomic status certainly impacts care, right? So outcomes if people can get to the doctor, if they can pay their copays, et cetera, pay for their medicines, that Black and Hispanic patients with MS seem to have higher morbidity, meaning more disability and mortality, which we already discussed. And one of the limitations is that there is low representation in clinical trials. And so that really limits our ability to understand why we're seeing what we're seeing. Also, the impact of systemic racism and other forms of discrimination can also affect those social determinants of health that we discussed last time. This is a paper that looks at we touched on this briefly last time, right? So one of the reasons we don't understand why we see the outcomes we see groups that seem to have higher risk, we see groups that seem to have worse outcomes, but we don't have the research to back that up. So when I first started doing talks focused on African Americans with MS, I could fit every paper that was written in one 3-ring binder. And every year before I got ready to do another talk during Black History Month or MS Awareness Month, I could literally read all the papers over and over again. That's how little literature there was to help us understand why we're seeing these outcomes. And although this paper was published in 2015 and the numbers have increased, they still represent a very, very small amount of the literature that's written about MS, and that certainly needs to change. So what is this thing about lack of diversity in clinical trials, right? So when we think about our MS clinical trials, although we have nearly 1 million people in the US who are affected by MS, most of our trials are primarily conducted in Eastern Europe. So when we look at the numbers of people, we use Black and Hispanic populations because those are the largest minority populations here in the US. We see that there's anywhere from 2.3% to 16% enrollment, right? For Black patients, and for Hispanic patients, anywhere from 7 to 7.5%. And some of the earlier trials really didn't even ask about Hispanic ancestry. So we don't have the data because nobody asked, right? So this is something that absolutely needs to be addressed if we want to better understand the outcomes that we see. So what are some of the barriers, right? So, one of the things that I really try to discuss, and Sheila and I were able to touch on it briefly, is we have to look at the way that we talk about enrollment in trials, right? So a lot of times we talk about it in terms of participation. And certainly there are some who don't want to participate in trials, and that's everyone's right to decide whether or not they want to participate. But we also have to recognize that there are larger barriers that may prohibit or keep people from participating in clinical research. Number one, some are not asked to participate because there may be this perception that they don't want to participate because of the Tuskegee experiment or because of other issues, right? Also, patients don't know where to find out about research trials. So if you're at a large academic center or a large MS center or a research center, then it may be very easy to find out about clinical research or be offered the opportunity to be involved in research. But if you're being seen in the community, you may not know that there are trials going on in your community at other places where you can seek care and still maintain your relationship with your regular doctor, even though you're being a part of a research study. Also, we have to think about sociocultural factors and perceptions about research. Make sure that those things are being addressed. Socioeconomic status, right? Can you get to can you get transportation to the visits for the trial? You know, how much work do you have to miss to be a part of a trial? We have to think about the burden on people who are participating. We have to also make sure that we address mistrust, and we have to look at the inclusion and exclusion criteria, and we'll talk about an example where that was looked at a little bit later on in this presentation. So why is increasing diversity in clinical research important? For a variety of reasons. So we know that certain groups are underrepresented in clinical trials. We know that there are unique differences in some populations, and not all of them are biologic. Some of them may be cultural, some of them may be environmental, but those things will be missed if we don't include everybody. Also, when we think about generalizing results, we want everyone to be a part of the study so that we know the results apply to everybody. Although we're majority the same, right? When we think about genetics, when we think about makeup, when we think about our organ systems and things like that, we're much more alike than we are different. But sometimes those little differences could potentially make a difference in treatment, right? And so we need to know that. If it doesn't, we need to know it. If it does make a difference, we also need to know that. The only way we know that is if everybody is involved. So this slide is just focused on the MS Minority Research Partnership Engagement Network. So this is an interesting group of people, doctors, people living with MS, other researchers, industry partners, advocacy groups. And so we said, well, let's just ask people, right? We're making all these assumptions. Why don't we just ask people with MS if they want to be involved in research and what their attitudes are about research? So we did a survey with about 2,600 people. And what we found was that most people were actually very supportive and had positive thoughts and impressions about clinical research. There were some things that we found that were a little bit different in some of the minority groups, that there was some mistrust. There was concern that people may receive poor quality of care. There also was concern about health insurance. And for people who were immigrants, there was concern about their legal status. Would that be in jeopardy if they were involved in some type of formalized trial? But by and large, many people wanted to be involved. Two of the major barriers that we found from this survey were that they were not asked to be a part of research, and they did not know where to find out about studies. So again, reiterating that some of these barriers are not just the fact that people don't want to participate, it's that they don't know how to get involved. Next slide. Basically, when we think about strategies to increase diversity in clinical trials, as I said, Sheila's going to touch on quite a bit of this, so I am going to keep this part of my presentation brief. But we want to broaden eligibility criteria. When someone is invited to be a part of a trial, there are criteria that make them eligible for a study or things that make them excluded from a study. And so sometimes when we make our criteria extremely strict, it can automatically exclude groups of people. We also want to make sure that there are recruitment strategies to increase diversity, make sure that the studies are less burdensome, that you don't have to come to the doctor 20 times to be a part of a study and miss work 20 times. And we also want to make sure that not only are we able to enroll people in trials, but that we make it an experience so that they can continue to be a part of that trial and maybe even want to participate in subsequent trials. Next slide. All right, so I'm going to talk about two examples and then I'm going to hand it over to Sheila. So one is the African American MS Registry. So I'm very excited and proud to be a founder of the National African American MS Registry, and we presented our first poster at the International Congress ECTRIMS back in September of 2021. Next slide. And we basically were able to present the results of our first baseline survey. So we had 100 people that completed the first baseline survey. Our goal is 10,000. Or as many as we can get, 10 to 20,000 Black people with MS in our registry. But we have currently about 400. So we present the results from the first 100 surveys. And what we found was that most people had similar types of MS to what we see in the general population. And we found that nearly 20% of patients were not receiving treatment for their MS. We also reported that a large percentage of the folks that we enrolled were seeing MS specialists, which we would expect because we started off at MS centers, but also that there was nearly a 4-year delay from the time of diagnosis, from the time of first symptom to diagnosis. So that certainly could be something that needs to be addressed. Next slide. And then I'll also talk about the CHIMES trial, okay, which is the first multi-center trial that is focused on Black and Hispanic populations of people living with MS. And we presented on this, and we actually just did an updated presentation at the Academy of Neurology meeting last week. Okay, and so essentially what we did when we tried to, create the trial was to try to look at things from the ground up. Previous slide, please. So we tried to look at things from the ground up. We wanted to really make it a collaborative process, right? So one of the issues is that oftentimes the researchers and the doctors are over here creating the trial, the patients are over here, and the advocacy groups are over here. So what we really tried to do was collaborate with different groups, right? Including there was a patient who actually was a part of the process of creating the protocol to help us to really think through how can we make this trial more inclusive and how can we make sure that we're reaching people in the right way, that we're using the right language with our education, et cetera. Next slide. Basically, the objective, we're looking at a medication that's already approved for MS, and I'm not going to go into very much detail about that. And we looked at patients who were aged 18 to 65. Most of our trials look at age 55, so we extended that a bit. And we also looked at folks who had, up to a pretty significant level of disability from their MS. Next slide. We looked primarily in North America, and interestingly enough, we actually wound up with the largest group of patients from Africa that have ever been included in the MS clinical trial. And so there's a site in Kenya, and we were actually able to enroll about 10 patients from that site, which would be the largest cohort of African patients, and hopefully make some comparisons about how they're doing with their MS. Also, we were very intentional about looking at the language, right? Making sure everything was appropriately translated into Spanish. We also looked at the financial burden and logistics, right? One of the barriers to people being involved in trial, they need flexibility in the schedules, right? They need reimbursement for travel and for meals, right? If you're there all day, you got to eat. Some people needed childcare expenses. So we looked at all those types of things to see how could we really support people and make sure that we made it as easy as possible for them to participate in the trial. Okay, and then also we looked at broadening the eligibility criteria, right? So again, when we look at inclusion and exclusion criteria, sometimes when we make very strict criteria where people basically almost have to have perfect health, right? Their diabetes has to be perfect, their blood pressure has to be perfect. And we know that some minority populations have more comorbidities like diabetes and hypertension. We can again automatically exclude folks because we're being so strict that we're going to miss out on a whole group of people. So basically, the goal of this trial is to try to increase understanding of biology and MS and also enhance equity through clinical research. And I'm very proud to say that we completed enrollment 2 months early during a pandemic, right? So again, we want to challenge this thought that the reason there's not diversity in trials is only because people don't want to participate. There are many who want to participate, but we have to look at the way that we do things and really revolutionize the way that we're conducting research so that we can make it more inclusive. Okay, so that's one example. Those are 1 and 2 examples. But I think in light of that, it leaves me with a sense of hope, because, we spent many, many years talking about these issues. But I think that people are beginning to try to move the needle to work to see how we can solve some of these issues and how we can make sure that everyone is included in research efforts and that everyone at least has the opportunity if they want to be a part, right? And I think the other, thing that is very important is, again, clinical trials are not for everybody, but there are many different ways to be involved in research, as we discussed last time. And with that being said, I will go ahead and hand it over to Sheila to help us better understand some of the solutions to this problem that's been going on for some time. And then I'll come back at the end and we'll have some discussion. I'll hand it over to you, Sheila.
Thank you so much, Dr. Williams. Excellent, excellent presentation. I definitely am impressed by the survey that you did, showing that people of color do want to participate in clinical trials, which is not the understanding of many people. And the CHIME study, what a powerful example of what collaboration can accomplish with regards to clinical research. So thank you and your colleagues for doing that. The data are clear. It's undisputed. People of color must be a part of clinical research. Clinical research is the foundation for the practice of evidence-based medicine. Physicians, healthcare providers need to know that products and drugs are safe and effective in everyone. So this is not something that's optional. It clearly is being driven by the disproportionate deaths and sicknesses among people of color, even if they're middle class and insured. And when we look at the census data, it's becoming a research imperative, because before the middle of this century, 1 out of every 2 Americans will be a person of color or a person of color who speaks Spanish. So these seismic demographic shifts are forcing us, challenging us to look at the way we've been doing things, and we must know they've got to be done differently if we're going to make sure that everybody has the opportunity to achieve their optimal health. Dr. Williams, Stewart, and I were talking before this webinar about the years that we have spent in meetings with many physicians, pharmaceutical companies, biotech companies, and we keep talking about the same thing. We need to increase diversity in clinical trials. Well, like the kids say in the hood, it's time to stop talking about it and be about it, so that we really can say that what we are offering to people to improve quality of life, improve longevity of life, can work in everyone. It's nothing new. However, government-sponsored trials, it's a mandate to have a proportionate number of people of color in the trials. For the private sector, for pharmaceutical companies, it's simply strongly encouraged. It's time to move the needle and make it a mandate across the board, especially since pharmaceutical companies conduct over 70% of the clinical trials that produce quality products for us to live longer and to live better. So we're at a pivotal moment in the history of healthcare delivery in this country, and clinical trials are the key. You've got to start with those molecules. You've got to make sure that what you are producing is safe and effective in everyone. Then we have an opportunity to achieve health equity. So I'm going to give you what I have learned over the past 30 years that I've been working with pharmaceutical companies. I've had the privilege of working on 14 clinical trials where the goal was to increase diversity. I've worked on 4 race-specific trials just for Blacks and Latinos. And all of them had challenges. All of them were very difficult for the companies, the sponsors, to understand what needs to happen. The 2 things that sponsors don't like to hear is that the trial is going to take longer and cost more. Doesn't necessarily have to be the case when you're reaching out to people of color, but that's always the perception. So the first and most important thing is to assess your own culture. I was part of the founding group for the National Center on Cultural Competence in Primary Care out of Georgetown University. And it was an eclectic group of healthcare professionals, of advocates, of patients, clinicians, and researchers. And we spent a day talking about cultural competency, which has kind of become a buzzword, and not many people really understand what it means. But we came up with this continuum. In order for you to better understand communities of color, you first have to do a self-assessment. Do you know your own culture? Are you able to understand how your own biases and prejudices affect your behavior with your teams, both internally as well as when you do outreach? So the bottom level, and we're sure nobody on this webinar today is in that level, is cultural destructiveness. Those are the people who want to cancel culture. Those are the people who want to make sure that everybody is all the same. That's destructive. We don't want people in that category, because when you stop addressing culture, you stop the conversation. You can't address the issues because you've made it sure that everybody's the same. Incapacity is when you have not had an experience of being with these communities of color. You've grown up in one ethnic group, lived with one ethnic group, socialized with one ethnic group, you've educated with one ethnic group. Doesn't mean you're a bad person. It just means that you have limited experience of what it's like for me and Dr. Williams to live in our skin on a daily basis. Then there's the group that's culturally blind. They say, I don't see color, I see character. Well, you do see color. When you say cultural blindness, you are really promoting exclusiveness rather than being inclusive. Yes, we all bleed red blood, but there are cultural differences that definitely affect our behavior. Pre-competence is MS Views and News having this kind of program. You know there are needs out there. You know that people want to do the right thing, but they don't know how. Basic cultural competence means you put it at the top of the agenda with regards to looking at communities. You understand that your team needs to be diverse. You understand you need education, and you really want to make sure that what you're doing is going to be respectful, celebrated, and it will enhance what you do. So the question is, before you reach out to any group, where are you? Is there a cultural deficit in what you know or don't know about these groups? Let's be honest, we all have something to learn, and clearly no one group has the benefit of knowing everything. So first, start with you. Where are you? Where's your team? Where's your company? Where's your organization with regards to cultural education? Next slide. So in terms of increasing diversity in clinical trials, in my experience, the key to success is getting a trusted community partner. If you or your team do not look like or speak the language of the group you're trying to reach out to, you better walk in the room with a group who's trusted, respected, and known. Dr. Williams said that in her presentation. That deep level of mistrust, distrust in the community has caused some reluctance, some resistance on the part of those who are really needed to be in clinical trials. So I'm going to share with you how you find those partners, how you work with those partners, and what those partners can deliver. And as Dr. Williams said in the CHIME study, it's a collaborative effort. No one entity can do it all. Next slide. First and foremost, why do you need these partners? Why do you need people of African, Hispanic, Latino, Asian, and Native American descent? Well, in terms of what clinical trials are about, there's a lack of information. Nobody really understands, what is a clinical trial? Is it really a trial, or is it a study? Then there's misinformation. Some people think that when you're in a clinical trial, you get the disease, that you don't have best quality care, and you are reluctant because you don't want to stop what you're currently doing that may be working. So we've got to correct those two. But here are the two that make the most impact: mistrust, distrust. And that's of society, that's of government, that's of big institutions, that's of big companies, that's of the healthcare system. So you've got to mitigate that, and your partner can help you do that. And then, as Dr. Williams said, the impact of social determinants, where you live, work, play, and pray, make a big difference. That zip code, that makes a difference in how you get care, if you get care, and what quality of care that you get. And then the systemic cultural deficit, that even if you do say you want to be in a clinical trial, when you get involved with the trial, you meet up with that systemic racism, that institutional racism, that structural racism, that organizational racism. So it's a daunting category of trying to increase people diversity in clinical trials, but you need the partner. Your partner can help you mitigate, lessen the impact of all of these things. Next slide. So first and foremost, before you even start, decide which ethnic segment you want to reach out to. You may not have the funds or the time to do all. And certainly African Americans, Hispanic, Latinos, Native Americans, Asian Americans, those are the four major segments. Which group do you want to include in your clinical trial? Second, where are these groups, geographically speaking? Are they in states? Are they in regions? Are they in neighborhoods? Are they in zip codes? Decide where to find the critical mass of these populations. And I'm going to show you a few maps to give you some idea of where to look. Then what's your budget? Many of the budgets for clinical research, there are millions and thousands of dollars spent on clinical research. What's your budget? And then more importantly, what's your timeline? In order for you to develop a relationship with a partner, you need time to do that, especially if you or members of your team don't look like those groups or speak the language of those groups. So get that straight first before you reach out so you can manage expectations and you're able to sustain the effort. Then what are your goals and objectives? What are the endpoints of this clinical research? There are several kinds of clinical studies that you can that people can become involved in. What is it with this trial? What are you trying to accomplish? What are the endpoints? So that you're clear in your mind as you talk to these groups, what you're asking them to participate in. And then as you develop these partnerships, what's success look like? How do you define whether you've done a good job, whether you can make some adjustments, or what exactly you have to do? So you got to be prepared to go after these community groups, but you must have these things clear in mind before you make any opportunity to reach out. Next slide. So here's an idea of where you might look. These are the top 10 states of the 3 ethnic segments in this country. So if you really want to find Blacks or African Americans, look at the states where you might find a critical mass. Then for the Hispanic Latino community, and then Asian and Asian American communities. But be careful here. Hispanic Latinos are a diverse group. There are a variety of countries of origin. There's Puerto Rico, La República Dominicana. There are all kinds of countries. So be clear about which group you're reaching out to. And then as far as the Asian and Asian American segment is concerned, there are 40 different segments: Japanese, Korean, Vietnamese, Asian Indian, and it goes on and on. So be very specific. And as Dr. Williams said, it's self-identification, but it's important for you to know where these groups come from so that you can tailor your message and select the messenger. And you can see that the United States, you have an opportunity to go in a number of places where you'll find the critical mass of the population. Next slide. Now do your homework. When you decide where you're going to go, where you know which ethnic group you want to include, and you want to make sure that you're bringing the right partners. So when I go to a new city or I go to a new region and I'm trying to do recruitment, I talk to people. Where in this community can I find a group, a church, a community-based organization, or a partner that can help me deliver this message in a trusted way? I live in New York. If I want to try to increase diversity in clinical trials and I go to Atlanta, I need to find some partners there. And there are people who know who those partners are. So I talk to elected and appointed officials. I talk to hospital personnel. I talk to physicians like Dr. Williams, who are more likely to treat people of color. Chambers of Commerce, that's the business entity. They have a vested interest in making sure the community is healthy and safe. So I ask them who needs to be a part of this consortium or this collaborative. Then the media. There are over 200 Black newspapers in this country. There are over 400 Black Latino papers, and Asian network is a huge network, even with the Native American. And I'm working in the Native American community now. So Indian country is diverse. There are 574 Native American tribes. So where are you going to go? And then last but not least, I go to faith leaders, because spirituality and religion are important in these ethnic groups. Pastors, priests, imams, spiritual advisors. I go to those people. I say, I want to come in and do a clinical trial on multiple sclerosis. I have Dr. Mitzi Williams, who's one of the nation's leading international leaders in research in multiple sclerosis. Who else should we bring in the room with us when we talk to community groups or we reach out? That's the homework. Before you step foot in the community, do your homework. Next slide. And then these partners, once you do decide which groups you want to reach out to, do they have a trusted voice? What is their reputation in the community? Do they have a staff or volunteers that can help you get the word out? Can they go store to store, barbershop to barbershop, beauty salon to beauty salon, African braiding store, to bodegas, to the community venues where you're going to find the population and you can talk to them about this clinical trial? What is their network like? Do they have a website? Do they have a regular meetings? Do they have events where you can publicize and put information out? Do they have a database that you can send information out to their constituents or their members? And do they have special events during the day, during the week, during the year? Is it after church on Sunday? Or is it at a soccer game in the community? Find these partners who, when you walk in the room with them, the community feels trusted. They may not know me, but they'll know who I walk in the room with, and that opens the door to a conversation. Next slide. And then once you decide the group, make it a formal collaborative. Dr. Williams talked about the collaborative she was able to pull together for the CHIME study. This is not something that you're just going to say, well, can you help me? Make it specific. Say, we'd like to work with you. We'd like you to work with us, and we'd like to learn and work with you. Go to the meetings of that partners, of that organization. You may even have to give a donation to them to show you respect the work that they're doing in community. And it's not all about what you want. You want to make sure that you leave something behind. Offer your assistance in whatever they're doing so that when you come and say, I really want to get the word out about this clinical study, they're more willing to help you. And send information about the disease. What do they know about multiple sclerosis? Do they have anyone in the community that is living with multiple sclerosis that can help you put a face to the condition and show how important clinical research is? So prepare to get that partner in so they're a real partner, not just an afterthought to pull in because they look like the group and they sound like the group. It's got to be better than that. Next slide. And then prepare for that contact. Make a phone call, write a letter, have a meeting, formalize the partnership. I want to work with you. We have this clinical research study that we're going to be doing for the next 8 weeks, 20 weeks, 52 weeks. I'd love to have you part of this process as we move forward. And make it formal and make it an announcement. Tell the community, I'm now working with some of the street healthcare workers in making this promotion and this possible. Make it truly a collaboration that's respectful, that's culturally competent. Next slide. And then educate, motivate, collaborate, and activate. Constant education. These communities, because of social determinants, have a lot on their plate. They're taking care of their families. They're working. They may be going to school. They may be challenged with having elderly relatives and children to take care of. You've got to feed information to them about MS. What's the latest research? Anybody that look like me is going to be in this trial. Are the principal investigators, are the clinical trial coordinators, are the people that are involved in the trial on a monthly basis of color? If they're not, get some groups of color. Retired nurses, retired social workers, even clinicians who are currently practicing. I always bring them in because more often than not, the clinical research team is not of the same race or ethnicity as the groups they're trying to attract. I want to walk in that office and see people who look like me. So I have the comfort level that what I'm going to be told and how I'm going to be treated is respectful. And make sure that that education is continual, not just before and during the trial, but after it as well. Motivate people. You're doing something to help you, your family, and the community at large. That's often a reason why people do volunteer for clinical research. And keep that collaboration going by communication, coordination, fellowship, and those are the opportunities you have to really build a strong network of people who begin to see that they can trust, they can be treated respectfully. Next slide. And once you do have these partners and they work well for you, recognize them, reward them, have the local elected official give them a certificate, have the local newspaper, have them in the paper. They participated, they were part of this collaboration. Reward them, acknowledge them, and that helps you to build community ambassadors. Then people will want to be a part of the group because they see how much good it's doing for the community. And keep in touch. Take photographs of the process of going out in the community and working with the community. Have meetings at the local restaurants. Make sure you show up at community forums, city council meetings, or whatever organization, PTA meetings. Establish a presence in the community so that when they see you, they know you're talking about clinical studies, clinical research, and they'll come to you to get information. And again, it makes it at least more friendly and more user-friendly for those who might want to consider being in a clinical study. Next slide. I wanted to show you an example when I was doing a program in Atlanta about where we wanted to go. And just to give you an example of doing your homework, when I looked at Atlanta, it's a big city, and Dr. Williams can certainly tell us about that. And I've been to Atlanta many, many times, and so has Stuart, and the programs that MS Views and News does. And we kind of looked at, where do we get the best opportunity to reach African Americans? Well, we looked at zip codes. Zip code 30309, the population in that zip code is 21,000 total, 16,000 white, 4,000 blacks, and 1,000, a little over 1,000 Hispanic Latinos. Well, maybe that's not where you want to go because the numbers are very small and your time and resources may be limited. But take a look at the places where you normally find people. There are only 18 beauty salons in that zip code, 7 churches, and 3 pharmacies. And we were going to put flyers in churches, flyers in the pharmacy, and certainly use the beauty salon as a way to talk to women. This was a trial with women. But then when we look at zip code 30349, total population is 68,000, white population 2,000, but look at the population of Blacks in that zip code, 61,000. And comparatively speaking, 35 beauty salons, 26 churches, 4 pharmacies. Well, you know where we went. We took students from the local community colleges and from the universities who were in biological sciences. We gave them flyers, we gave them brochures, and we put them on the ground. We put boots on the ground, and we distributed those materials in the 35 beauty salons, the 26 churches, and the 4 pharmacies. We did this in a number of zip codes. So that's what I mean about do your homework. Go where the fish are biting. Go where you're going to have the critical mass of the population, and in turn, you can have that success. So you've really got to get in the weeds here. You've got to be methodical and intentional so that you reach the population, you have the right partner, you put their faces on the brochures, you make sure that they're involved in moving in the community and talking about clinical research. Next slide. And all that stuff is online, all that data of those churches. My team does that. We go in and we peel the onion. Where are the Black folks? Where are Latinos? Where are the Asians? And we find them. And then some of the partners you might want to consider are the major organizations that really are doing the work in these communities. National Medical Association, 50,000 Black doctors. National Black Nurses Association, 150,000 Black churches. Black Pharmacists Group. Jack and Jill, one of the major community-based organizations that many Black women are part of. Links, another organization that's driven by community service. NAACP, National Urban League. I was telling Stuart and Mitzi and Dr. Williams that there was a study released today about the state of Black America, and the statistics in terms of health are not good. So we've made some progress, but we have a long way to go. Then you have fraternities and sororities. We call them the Divine Nine, historically Black colleges and universities, church health ministries. These are the groups that you need to bring into your collaborative to help you deliver the message in a trusted way. And there are similar organizations in the Hispanic community, the Asian community, and the Native American community. Next slide. And the media. 1/3 of Black adults trust information from the local news organizations. And those newspapers are weeklies. They're often distributed in barbershops and beauty salons, laundromats, check cashing stores. Get your information in those vehicles. Why? We trust them. They talk about us. The people who publish them look like us. So if that's where you need to go, your ad may be in the New York Times, maybe in the Daily News, maybe in some of the mainstream media. They may read those publications, but they trust these publications. Find them, and you'll be able to get your word out. Put a picture of Dr. Williams in it when she's involved in multiple sclerosis. Even though she may not be in that city, they want to see her face. And they understand that there are people who look like them involved in this trial, and maybe I should give some attention to what these folks are trying to help me to do. Next slide. And then, of course, radio is clear. Music is the medium of choice in these communities. So using radio, public service announcements, 30-second spots, having Dr. Williams, her voice, having your community partner, the organization's voice. This is brought to you by Dr. Mitzi Williams. That means something. That sounds like me. So I want to hear what this woman has to say. These media are ignored in most of the organizations that I have worked with in clinical trials, and that's a mistake. You're overlooking a huge opportunity to reach out to these populations. Next slide. And of course, social media. Black, Latino, and Asian people over-index in their use of social media because they want to talk about people back at home in Africa or in the Caribbean. So use social media, cheapest, fastest way to get the attention of these communities. Next slide. And then once I put all that together, I do a strategy that I call surround sound. I want to hear it in church. I want to get a brochure in the beauty salon. I want to see it in the pharmacy. I want to hear it on cable news. I want you to hit me in every possible way you can with this message. And at some point, you're going to say, I think these folks are trying to get my attention. So you've got to be prepared to make sure that you saturate the community with your information and with your invitation to be a part of clinical study. And you create a culture of trust by the right partner, by the right message, by the right graphics. Next slide. And remember, this is not a 60-day event. This is going to take time. You got to build in time before the trial begins to develop the partnerships, to do your homework, to make sure you've got the right people in the room, and you manage those expectations. And more importantly, be patient. And I usually put on this slide, be prayerful, because you will have success. I know you will. I've had success. And it's not a difficult thing to do. You've got to be intentional, methodical, committed, and focused. Next slide. And that's the end of my presentation. So Stuart, join us, please, Dr. Williams and I, so that we can have a further discussion and maybe entertain some questions.
I want to say that was
Amazing.
amazing, all right? But I want to say that if we were in a theater somewhere, I would be the first one jumping on my feet, screaming bravo for both of you, all right? That was an awesome, awesome dialogue, and I only wish that the people who needed to be on this program were on this program, all right? I mean, I see who we have in attendance, but we have got to find a way, and I was speaking with Sheila before the program began, that I want to get you both, all right, to different portions of the country for us to do in-house, in-person programs. And area code 30349, this is where we do our programs when we come to South Atlanta.
Oh,
So that's
by the
wow. That's near the airport area. It's by College Park or the East Point area.
That's
and
right.
Yeah, that's where we target. We targeted when we did a program in Memphis. I mean, we had predominantly an African-American audience in Memphis. The same thing in Greenville, South Carolina, when we were there. There was very few non-people of color in those audiences. And so that's what we're targeting when we're out in certain urban areas around the country. And I would love to be able to do a program like the two of you just spoke about tonight. I want to do this live, and I want to take it on the road. And the only one we got to really get out of her office is Dr. Williams. All right, so we're gonna have to work that out, because her schedule, I know, is ridiculous. All right,
take care of patients. I don't want to pull her out too much. She's too,
right.
she's too valuable. Yeah.
Exactly.
Yeah.
So you know, I want to get into all these different things. We have questions that have come in online. Fortunately, there's some very good questions there. But you know, one of the first ones that I want to ask you is, I know a lot of this is breaking down the barriers, all right? But how do we get organizations to get beyond just the talk and actually to do?
Yeah, so I think that I can start, and you know, Sheila certainly, I'm sure, has a lot of insight where this is concerned. You really have to have a champion, right? You know, so oftentimes there's a champion either within the organization or someone who has partnered with the organization in some way, that says, you know, hey guys, let's come up with deliverables, you know, because oftentimes there's a lot of talk, there's a lot of meetings, everybody wants to have a meeting, but, you know, there has to be a champion that wants to get beyond that step of talking to actually do something. And then when that champion is able to collaborate with other people in the community that can help bring together those solutions, then often change happens. You know, I will say that the CHIME study actually was birthed out of a steering group. So I'm the only neurologist on the group. You know what I mean? And so, you know, we have all these amazing people who've been doing all this great work in health equity, you know, and MS is very much kind of, you know, really just starting to do work in this area. And so we were able to collaborate with some, you know, great folks who've been doing work in oncology, you know, that are kind of light years ahead in some of the concepts that we're trying to grasp. And that's what it came out of, a group of people that were doing something totally different that said, well, hey, if we want to find the answer, let's try to do this in a different way. So I think, you know, it starts with that champion or champions in the organization that then kind of are able to extend that and bring in other partners and collaborators to really move the needle.
Great. Thank you for answering that, Sheila. Would you like to add to that, please?
Just something very simple, and Dr. Williams is absolutely correct. I come from the perspective of I need resources. I'm not going to these groups with cup in hand. I want to go to these groups and say, I'm here to support you. How much will it take? How much do you need? I don't have a bottomless pit. I've got finite amount of dollars, but you got to give them something. You can't continue to use these groups and say, do it for nothing. Why should they? Okay, so you've got to come with a budget. So I would focus on the sponsor. What's your budget to do outreach? What's your budget to make these partners feel as if they're truly valued and you're not exploiting them or
Right.
using them?
Yes, absolutely. Spot on. Spot on.
Great. All right, so let me get into the questions now. And we have about, I think, 6 or 7 questions for now. And maybe this line of questioning, maybe other people online will realize things that they want to ask. All right, so the first one, I'm not going to mention names of anybody sending in their questions. Are there any patient advocacy organizations specifically supporting the by people of color communities? I don't understand by being by people of color communities nationwide as it pertains to multiple sclerosis.
So there are some organizations that are focused on certain segments. So for instance, there are groups such as We Are Ill, which is a collective of Black women with MS that focuses on issues related to Black women with MS. There are other influencers. There are other kind of smaller groups, like we have some local groups here in Georgia. There are groups in other states. Oftentimes there are support groups that are focused on people of color. So that might be a good place to start, looking at resources with some of our national organizations to find out about where are the support groups in your area. But certainly those are the ones that I know of. There are other influencers, but in terms of collectives, there aren't as many collectives that are actually formalized groups focused on, people of color with MS.
And that always is a challenge when it's considered a small disease or an orphan disease. That's a challenge. But sometimes, Stuart, I have gone into communities where these broad community service organizations, I teach them about MS. Do you have a family member? Do you have anyone that you know of that is living with MS? And I try to help them to see how this program can help them. So sometimes you have to create your own group in certain markets. So you go to the church, you go to the Urban League, you go to the NAACP. Did you know about MS? Many of them don't. So you may have to educate and create your own ambassadors, your own group. And they may obviously learn from the ones that Dr. Williams talked about, but don't let that stop you. The community wants to help the community. That's what we've always done for each other. So, you want to teach us, give us what does it say, Dr. Williams? Don't just give us a fish, teach us how to fish.
Teach us how to fish. Yep, absolutely. And so that is something else that I often talk to, my patient advocates about. If there's a need or you see a gap, whether it is working moms with MS or whether it's focused on, people of color, people who like to work out with MS, whatever it is, maybe that's the niche for you.
Exactly.
To really step in there and create that thing that's missing.
Exactly.
Yep. So here comes another one that's a wild question to ask, but lots of people that hear people of color only refer to this as the African American community. And can you give any other definition of that other than it being just one community?
Yeah, that's a great question. And I think one of the questions, Stuart, you said by people of color, BI, BIPOC. Right. It's Black, Indigenous people of color. Gotcha. And again, I think the misunderstanding is people of color has nothing to do with the pigmentation of your skin. It has to do with shared experiences of bias and discrimination. So it's not just about color, it's about the lived experience of these groups. So we're not talking about just people of African descent, because there's more diversity within groups than between groups. So when you say people of color, it's not about skin color, it's about shared experiences. And that translates into Asian, Native American, and the new group that the census has put forth, the multicultural populations, people that are bicultural. They've checked 2 or 3 boxes on the census. So who are they? Whoever they think they say they are.
So you saying, you giving this description, I think this is what really the world does not recognize, because most people understand just people of color as being maybe the Hispanics, the Asians, the African Americans, and the American Indian. And, even the American Indian is really a far underserved community, I think more so than probably anybody in the United States, right?
Absolutely.
Okay, so And we'll get into that at one later or another time as well. All right. But
Sure.
right now, let's go to the next question. All right. So, and this is pretty much in line with what we were just talking about. The person writes, I doubt that they are not asked. I guess that's, I don't know who yet. Let me finish this. What I find with white and Hispanic in my area are a lack of interest to follow through. Your thoughts. And that again goes to like probably with what I was saying earlier. A lot of the people that need to be on listening to this program are not here. So how are they ever going to learn to break those barriers?
Mm-hmm. So, so again, I think that, as Sheila said, there are many different ways to reach people.
Mm-hmm.
I also think that, there are many different people who are trying to do this work, right? So I do this work. Sheila does this work. And we both are in many different venues doing this work. So the goal is, hopefully if I shout it from the rooftops from as many places as I can, that somebody will get it and spread it over here, and spread it over there. But I think that, again, that is the whole point of collaboration. It's not just one group that can do it, right? So MS Views News can't do it by themselves. This society can't do it. Dr. Mitzi can't do it by herself. Sheila can't do it by herself, right? So we're all looking to spread the information within our spheres of influence, so that as many people can get the information as possible. But it's not all going to be gotten in just one place.
And let me help your person who asked the question understand. They observe the lack of follow through or the lack of commitment. You must be able to understand the dynamic of living in your skin as a person of color. You've got rent, you've got kids, you've got job, you've got education, you may have elderly relatives, you may have children. That lived experience may sometimes prohibit someone from doing what they really want to do. So it's not that there's no willingness, it's just that societal social determinants prevent them from doing it. They've got to put food on the table, they got to pay rent. So they may want to be on this, but they may be working 2 jobs. So you've got to understand, walk a mile in their shoes before you judge them and immediately say there's no follow through. There's a reason for that. And if you get to that reason, maybe you can help facilitate them being a part of this.
Right. And that's a similar way that we talk about things like compliance, right? As the physician community, we have to make sure, and I educate my colleagues a lot about being very careful, right? Somebody's not compliant. They're not doing what you told them to do, but there are reasons for that. Maybe they're not exercising because their neighborhood isn't safe. You know what I mean? Or maybe they get home at 12 o'clock at night. So again, we have to look at the whole picture and really get in and ask people and not assume that we know why things are being done or why things are not being done. We need to get in and we need to ask.
Walk a mile in their shoes before you judge them.
Absolutely.
True. And as far as people providing programs these days, so a lot of it is done, in person, like we were discussing, and on live stream as well, whether it's live stream or a Facebook stream or whatever stream it might be. But this way you can bring in more people than what you could have possibly only had, because maybe the person can't get a sitter. Maybe they got a bunch of little kids running around. You can't get a sitter and you can't get out to do anything. Or the husband or the wife or the girlfriend or the boyfriend, the significant other is working and they just don't feel like they want to go by themselves.
Exactly.
So I understand that. So yes, I have a lot to learn as well. I got it.
We all do. We're all learning.
Let me also mention one thing about the digital divide. Not every family has the capabilities of a nice computer that, individuals. Sometimes there's one computer for the whole family, so clearly you can't determine why someone may not be online because they just may not have the opportunity. I worked on one clinical trial where the participants had to submit their data to the clinical research team on their phones. Well, this one gentleman said in his neighborhood, there aren't enough towers. He had to drive to a mall to get a signal so that he could definitely send that information into the clinical. Why don't they do that? Well, because the phone companies don't think those neighborhoods deserve that. So again, we're talking about society. Those inequities are built in. And so the community has no choice. They could have to work with what they have.
Right.
Yes, totally. I understand that. I even find that the phone company doesn't want to put in towers where there are good areas. It's just, I don't know what the deal is.
It's all about money.
They want them on their cell phones instead or something.
That's right. That's right.
Right. Okay, next one. It does seem to be related to knowledge of how, where, time to participate. What are your thoughts to improve this? It does seem that it may be related to knowledge of how and where, time, or having time to participate. I think that's what you were just talking about, though.
Yeah, I think Dr. Williams mentioned that too. Yeah.
Yeah, so I think, again, it goes back to many of the points that Sheila made, right? This is not a problem that's going to be solved instantaneously, right?
Mhm.
But it does take intention, and it does take planning and investigation,
Mhm.
right? So, when we're looking at, so again, all of the onus is not on the people who want to
Mhm.
participate. The onus is also on the healthcare community as well as the industry partners that are creating the trials, and so that's why I think it's so important to have this, collaborative, broad approach, because we have to make it easier for people to participate. If we want people to be a
Exactly.
part of it, we have to do the work to make it easier and make things more accessible. So certainly, again, there are many people like Sheila doing this great work, but we still got a long way to go.
We
We
do.
still
That's right.
Can I
So,
share something, Stuart, before you move on? I worked on one trial that was targeting Hispanic
can I say
Latinos.
yes or no yet?
Yeah, I knew you were going to say yes. And they got the participants in the trial, but diet, as Dr. Williams can tell, is often a factor. You can't always eat everything because whatever your diet is will impact the efficacy of the drug. So they were giving this brochure to Hispanic Latinos for this 52-week trial. And the brochure on diet said, first page, do not eat fried, greasy, or spicy food. Well, you could you giving that to Hispanic Latino? That's
Throw
what
it in the
many of
chat.
them eat. So,
Right.
so Dr. Williams, they looked at that brochure and said, sorry, not going to be in this trial. So
No
what did
way.
we do? We got a Hispanic registered dietitian to help those participants to tailor their food so they could enjoy their culinary preferences without just negating everything. So
Right.
you've got to do that cultural spin to help people understand that,
Right.
you can be in this trial, you can enjoy what you want to eat, even though it may not be exactly what you want. You've got to think of those things in advance.
Mm-hmm.
Okay. So the person that wrote about the BIPOC earlier that I screwed up did write that it was Black, Indigenous, and people of color, and that was a fantastic explanation of and clarification from Sheila Thorne. So I just want to let you know what this person said. So
Thank you.
basically what he or she was doing was sticking a nail through me and saying I screwed up. Right? Okay. All right. No problem. So
You learned something new today, Stuart. You learned something.
exactly. And
That's
that's
what it's
exactly
all
what
about.
it is. Everything.
It's a journey.
I like to learn. I purposely turn on whatever it might be so I can learn the things that I need to do for others. Okay.
Mm-hmm.
And myself. All right. So another person, before I get back to the questions, another person is saying, is there a way to get a copy of this webinar? The answer is yes, but you're going to have to wait about a week. All right. Because I am still processing things that were from the end of March to get onto our YouTube channel. So hopefully I'll be caught up by the end of next week. And then you'll also see the program that we did last week with both Sheila and Dr. Williams, and you'll see the one from tonight as well. All right. And what I'll do is for everybody that's been registered for these programs, we have you on a spreadsheet. So when we get them posted onto our YouTube channel, we will send out an e-blast to all of you to let you know that it is on the YouTube channel, and then you could share it however you wish. You want to bring it to other meetings, please do. You want to bring it to support groups, please do. Share with as many people as you can. Thank you. All right, now let me get back to the questions. For those who are immigrants, etc., do you believe that consent is a barrier?
So absolutely, right? So it can be if things are not translated appropriately into different languages. So all Spanish translations are not equal. Some of them make a lot more sense than others, So it's not like you can just go to like Google Translate and take the words and just put them over. You really have to have people who are experts at really describing that language to make sure that things are translated appropriately, so that things read well. And then even with that, when you think about consents, as Sheila mentioned in our last conversation, they can be very long, right? So even if they're in English and you're a native English speaker, getting through a consent form can be difficult. So it's even more important to have people who, can communicate with people who are non-English speaking and really help them to understand that consent as well. So I think that both of those are definitely keys, to making sure that people understand what's going on. And it can be a barrier if you're missing either of those resources.
Absolutely. The immigrant population is continuing to grow in our country. And people often think that they are uneducated, illiterate, and they're outsiders. But the recent census says that 7 out of 10 of the immigrants are naturalized citizens. They speak English. You've got to go to them in a slightly different manner. And Dr. Williams mentioned the fear of immigration, the fear of being tracked or found out is serious. So you've got to go into that community with those trusted partners, even people of African descent. Most of the African Americans in this country come from Western Africa, Eastern Africa. So they bring that culture with them. And in that household, you may have immigrants as well as those born in this country. So it's diversity within diversity.
Mm-hmm.
Right. By the way, there was data that came out recently about the amount of immigrants that are coming to our shores now versus 100 years ago. And it is far lower now than it was 100 years ago.
Yeah.
So it's just a variance, so 100 years ago was primarily people coming in from Europe. Okay. And now it's just, other, like you said, from Africa and I don't know where else, but I would say that
Africa, the Caribbean,
Asia, Asia has a lot coming in as well. So, all right.
And I think,
question.
and can I say one more thing that I've been thinking about as Sheila's been talking? We also have to make sure that we have outreach to understanding of who helps make medical decisions within a family, right? Because sometimes it's not just that person. There are other people who are primary decision makers. Like I'll never forget a patient that I was treating with MS. Well, it wasn't my patient. It was one of my partner's patients, but I happened to be seeing that person and he wouldn't go on treatment because his mama said he shouldn't do it, right?
That's right.
And that was she was a very strong determining factor in medical decisions, even though he was an adult, right? And so it's not always the mother, but there's sometimes our other players, right? If they read about that trial and then go home and, auntie says, no, this is a bad idea, we got to educate auntie too,
Absolutely.
Because they can help either say yay or sway against certain decisions, about research and other things.
Right. All right. Next one. Person is asking, do you have any Hispanic presenters? I don't know if that question is for me or you guys. The answer is yes, we use Hispanic presenters. It's not as often as we used to, though, because most of the programs need to be discussed in English. So it doesn't really matter if it's if it's a Hispanic presenter or not. When we have done programs solely in Spanish, the younger audience had no clue what was being discussed. Actually, they understood what was being discussed. They didn't understand the PowerPoints because they don't read Spanish. They speak Spanish, but they don't read it. So we started doing some that were truly bilingual. So we had a presenter one time make the slides in English and Spanish. But it's a lot of work. It's a lot of work. So.
Well, that's what I was talking about with clinical research in the communities that speak foreign languages. It's going to cost a little bit more because you have to have translation. As Dr. Williams said, it's not just conversational Spanish. It's got to be medical people that can translate into a Spanish that's, medically correct. I've worked in the Dominican Republic and in Puerto Rico, in Argentina. So that population, definitely language is a common thread, but it's different. So National Hispanic Medical Association, I work with them often, and they certainly can be a source of providers and community people to help. Unidos, Univision, those are all of the elements in the Hispanic community. We may have talked more about African American, but it goes across the board.
Okay, thank you. Next question. Next question is a statement. Thank you, MS Views and News, for providing A diversity presentation is very important to see, very important and great to see it addressed. Well, thank you very much for your comment. I greatly appreciate that. Next question. It's important to find the community, but it's more than that. When I did my dissertation involving nurses, and I was a nurse, not me, this person, I went to hospitals and had a difficult time recruiting. Do you believe that it weighted towards communication? Weighted toward communication.
I'm not quite sure what the question is, but I do think that institutional issues can be a barrier. You might think that healthcare professionals would be totally on board with what we're suggesting, not necessarily. Having Dr. Williams is a rare jewel in terms of providers who really are focused not just on their clinical expertise, but the community expertise. That's rare.
She's not going to sleep tonight. You've been building up her
I know,
so
my
much,
head is getting so big.
She's
The other
floating
thing that,
all night.
the other thing, right, because my head is a balloon. The other thing that I would add, as Sheila said, sometimes there is red tape with certain institutions. And I think, again, when we think about revolutionizing the way that we do research, we have to look at doing research in the community, right? Private practices. I mean, we definitely, our academic institutions are amazing, right? They produce a lot of research. There are a lot of people that are very focused, very dedicated, and a large percentage of their career is research. But how do we also partner with people who are in the community that maybe have a little bit less of that red tape to being involved, and also maybe actually serving some of these communities that we're trying to reach? So I think that, a combination of looking at different ways and different partners in doing research would definitely make recruitment a little bit easier as well.
Great. We have one question remaining.
Okay.
For now. Okay. Is the only focus on clinical trials? What about other studies such as exercise, meditation, physical therapy? What are your thoughts with remote studies or internet surveys, and et cetera?
Yeah, so I'm a founder of the National African American MS Registry. It's a survey, right? People can go online. They don't even have to go through their doctors and complete the survey, right? In terms of research, my philosophy is get in where you fit in. If a clinical trial is not for you, you can do something. You can do a survey, exercise study, diet, whatever it is you're interested in. So all of those things are extremely important. I think the reason the focus is on clinical trials is because that is the research that we use to determine our therapies, right? If they're effective, if they have the same side effects in certain groups. And so it really has the potential to have a very major impact if everyone is not included in those type of trials. Another thing that's really important about our clinical trials is that the research is very regimented and everyone has access to care, so to speak. So it helps us to better understand what's the interplay of those social determinants, right, versus just the effective treatment. Because if we eliminate some of those social determinants and everybody gets free medicine, everybody gets free MRIs, everybody gets care when they have a relapse, then it allows us to see really more what's related to the actual disease process and not related to you can't get to the doctor. So those are some of the reasons that we're focusing on that. But certainly all research, wherever you can get involved, is important and can contribute to the body of knowledge and helping everyone living with MS or other chronic conditions.
Okay, thank you. That was the end of those questions. Now I have a question to ask you.
See, this is what Stuart wanted to get to. He wanted to get to his question.
Started and ending, okay? And this is for the benefit of everybody that needs to hear this. Obviously, it's where is the best place for people to learn of clinical trials across the country or in their own backyards?
In terms of what clinical trials are available?
Where can they find out?
Oh, okay.
Where can they find out what's going on? I mean, I know the answer, but I want you guys to say it.
Right.
So there are a lot of different ways to find out, right? So nationally, not cdc.gov. Oh God, clinicaltrials.gov.
That's it. Yes.
It's a hard site to navigate, right? But if you just want like a kind of 50-foot view of what's going on, some long names and protocols probably that are hard to understand, that's a good place to start, right? Now, if you're looking for something locally, Generally, I recommend people look at academic centers that are near them, right? So they're usually universities that have MS centers, and often those centers run clinical trials. And just because you participate in a clinical trial does not mean you lose your doctor, right? You can still stay with your doctor and participate in clinical research. So I generally would tell folks, call up the research department. The numbers are usually on the website, online. Call them up and say, hey, are you running any studies? I'm interested in hearing about some studies. Now, you can ask your neurologist if they are doing trials. You can ask them about it if they do trials, but oftentimes if you're with a community neurologist, they may not be running clinical trials. So, the easiest place, call your local university where they have a MS center, and ask them, and they're happy to talk to you. They're happy to give you as much information as you want, because they want you to be a part just as much as you want to be a part.
That's great. Thank you for that. And by the way, clinicaltrials.gov has a search box where you can search for a trial. All right. And I know because I just did it. Okay. And all that time that Dr. Williams was just talking, before I wanted to tell you that, I wanted to make sure that it is still there. And it is there. But there's a few drop downs to reach before getting to that. So just click, and find your search and type in what you want. If you want to find something about multiple sclerosis, type that in. If you want to find something specifically on African American studies, maybe it'll be for you, or something that's on indigenous people, okay, or BIPOC, or whatever, whatever it might be. But maybe you'll be able to find something like that. So again, I'm glad that everybody was here. I'm awesomely glad that the two of you were able to participate in this program that we put together, and I can't wait to do it again. And I really do want to get down to Atlanta. I want to go up to Atlanta. Maybe we could just all merge in Atlanta, and we'll do a program in Atlanta. We'll do this in East Point somewhere.
There you go.
It'll be packed. It'll be packed to the max.
There you go.
Hope so. I hope so. Okay. All right. Well, thank you, everybody, for being online. And I do want to thank, of course, our supporters who you have seen all night behind me online. And we have Genentech and EMD Serono. Well, EMD is over my shoulder, or my other shoulder. Okay. And Biogen. But they're all there, and they are supporters for this program series. And we hope we could do this again in the coming months or years. And we look forward to seeing you all back again. Thank you very, very much for being online. Bye-bye.
Thank you so much.
Thank you, everybody.
Bye. Be well. Stay safe. Bye-bye.
Thank you.